dramatically in recent years. Both phenol and botulinum toxin type A effectively reduce spasticity by preventing neural communication with muscle. However, they do so by very different mechanisms of action. The understanding of these mechanisms can help the physician to understand the differences in their clinical application. Botulinum toxin type A affects the axon terminal at the neuromuscular junction through binding, internalization, and inhibition of acetylcholine release. It must enter the nerve ending to exert its chemodenervation effect. Botulinum toxin prevents release of acetylcholine at the neuromuscular junction. To understand how the toxin works, let's first look at normal acetylcholine release. Acetylcholine is packaged in vesicles and released from the nerve when the nerve is stimulated. These vesicles migrate to the plasma membrane, where they must complex with various transporter proteins, including SNAP25. These proteins allow the vesicle to fuse with the plasma membrane, releasing the acetylcholine. Botulinum toxin enters the neuron by binding to an acceptor on the neuron at the neuromuscular junction. As the toxin approaches the presynaptic membrane, the heavy chain binds the acceptor. Once bound, the plasma membrane internalizes the toxin. Once internalized, the heavy chain forms a channel which permits the light chain to enter the cytosol. The light chain binds and cleaves a section of the transport protein SNAP25. SNAP25 cannot now bind to the vesicle protein complex, acetylcholine cannot be released, and muscle contraction is inhibited. Botulinum toxin causes reversible denervation atrophy. Initial reinnervation occurs through the formation of nerve terminal sprouts. A slower but complete restoration of functionality to the parent terminals then occurs, accompanied by elimination of the sprouts. Phenol's mechanism of action is to denature protein, causing non-selective tissue destruction in the injected area, including coagulation of nerves and muscle necrosis. Wallerian degeneration of neurons occurs in the weeks following injection. The microcirculation around the nerve may also be affected, possibly accounting for longer-term effects. Most axons eventually regrow over a variable period of time.
There are two types of phenol injections that have been done historically. One is called the motor point injection, and the other is the motor nerve block. These are very different procedures with different outcomes and different technical requirements. The motor point block is an intramuscular injection done generally in the belly of the muscle, utilizing electrical stimulation technique to isolate the small motor branches of the nerve innervating muscle fascicles. This requires multiple small dose injections using very careful technique. This gives you a graded response. That is, you can get a partial or more complete reduction in muscle contraction using this technically very difficult form of injection. This is quite different than the motor nerve block, which is carried out by using electrical stimulation, placing the tip of the stimulator as close to the nerve as possible, and then infusing a very low volume of phenol. What you end up with is a complete blockade of the nerve if this is done correctly. And this points out the difference between the two techniques. The motor nerve block, the goal is complete reduction of that muscle tone. The motor point block is a graded reduction of tone. Unfortunately, the motor point block is, again, technically much more difficult, and the duration of response is extremely variable.
In summary, the motor nerve block is a perineural injection with a low volume of phenol, providing complete blockade and complete reduction of tone. The motor point block is a more difficult intramuscular injection, targeting the small motor branches using a large volume of phenol that gives a graded but highly variable response.
The technical requirements are that the injector understand how to do electrical stimulation to isolate the nerve, that they understand the functional anatomy of the limb that they're treating, and that they are skilled in using the needle to put the phenol where it's desired.
Botulinum toxin type A is injected directly into the spastic muscle either with or without electrical guidance to provide a dose-dependent graded weakness. The effects of botulinum toxin type A usually reach their peak within 2 weeks, and clinical effects persist approximately 12 weeks. Reinjection is then possible at that time with a dose adjustment based upon the clinical response.
The chemodenervation therapy plan includes muscle selection, dosing, injections, adjunctive therapies, and evaluation of outcomes. A working knowledge of primary clinical patterns of muscle spasticity is essential to individualizing therapy. Even though chemodenervation is a focal treatment around a joint or series of joints, untreated muscles may benefit also. This is due to the disruption of synergistic patterns that often replace isolated muscle control. In addition, adjacent muscles usually have some reduction in tone. Controlled tone reduction through phenol or botulinum toxin type A injections must not interfere with patient function. Since it is not always practical to treat all targeted muscles in one visit, the clinical team should prioritize them. Synergistic muscles or sites remote from the original injections may need to wait for follow-up treatment. Additional problematic muscles may be exposed by previous injections, requiring subsequent injections as well.
You know, after a stroke, obviously, you've got arm and leg involvement, and that's true in Mr. Zennewick's case. And so often you have to prioritize which one you want to target first. I've found that if you split the dose between the arm and the leg, that sometimes you get a mediocre effect in each. So what I've been doing more now is I'll target either the arm or the leg and then have them come back and then work on the other one. In Mr. Zennewick's case, we've decided to really target the leg.
Graded degrees of tone reduction can be achieved by varying the dose of phenol or botulinum toxin type A.
Use a 6% solution of phenol, which we drop, and typically about 1/4 milliliter is more than enough, so that's in the syringe. I'm going to explain a little bit about what our goal is, and then we'll have Julianne, the therapist, check you over as well and see how your muscle tone is. There were two primary problems for this lady who has had C1-2 injury with a spastic quadriparesis. The two issues in terms of daily cares had to do with the left shoulder spasticity and left elbow spasticity. And the left shoulder spasticity has been managed with Botox injections of the pectoralis muscle, which have helped improve the range of motion of the shoulder to this extent, which is quite a nice improvement, isn't it? That's very nice.
Yes.
But the big problem has been fluctuating spasticity due to biceps spasms. And this is quite variable. There are times when it's an Ashworth grade 2 tone, and she can get out to about 90 degrees, and there are times when it's Ashworth grade